Good evening, everyone. My name is Edina Francis Makwabe. I'm the consultant physician and nephrologist working with Africa's Care Network in Tanzania. I would like to welcome you into today's AHN Nephrology Education webinar and today's series number 101. Yeah, so the topic of today is health-related quality of life, palliative care needs and survival among patients with end-stage kidney disease. And it's a pleasure and have great honor, to welcome our today's speaker, who is Dr.Peace Bagasha. Dr. Peace is a founding member of Uganda Kidney Foundation. She's also a member of ISN Education Working Group, and she leads nephrology course, Department of Internal Medicine at Makerere University in Uganda. She's a lecturer at the Makrere University at Mulago Palliative Care Unit. And she's a specialist physician and nephrologist at Mulago National Referral Hospital in Kampala, Uganda. So she's going to talk about health-related quality of life, and palliative care among patients with end-stage kidney disease. And Dr. Peace, you are warmly welcome, and we are ready to and excited to listen to you. You're welcome, Peace.
Thank you so much, Dr. Engina, for that really good introduction. I'm very excited, very privileged to be here today to talk about end-stage kidney disease. So it's a topic that I've been interested in for a very long time, of course, being a nephrologist, but also what kind of care we provide to our patients who have end-stage kidney disease. I would like to start off by presenting this case, and we'll wrap up the presentation with the case as well and talk about the case. So this is an 18-year-old boy called Kato, who is from rural Uganda. He presents to the National Referral Hospital for the very first time with generalized body swelling and oliguria. His creatinine, when you measure it, is 21.4 milligrams, which translates into 1,800 millimoles. And his potassium is raised, as well as having a low HB, and ultrasound scan shows that he has small kidneys. So he's basically end-stage kidney disease, and he has presented at end stage, which is what we usually see from our patients. So the question is, what do you think Kato and his family need, and how will you approach this scenario? So as we go through, we shall try and find an answer to this. So the learning objectives today really is to talk about palliative care and renal supportive care and how they fit into each other, to explore what matters to patients and their families, and to see how to provide holistic care at the end of life for our patients. So I thought this is a good quote to begin with, one of the quotes of Hippocrates. He has so many, but this one in particular is trying to ask care providers, to try to have some foresight and insight, because they have a lot of knowledge and a lot of experience, and they should hope to impart this onto the patient when you see the patient. This is a quote from one of our patients, which shows you a patient who is looking back and trying to think and say that maybe if I had known, I would have made better decisions regarding this disease. So my study was comparing health-related quality of life for patients who have end-stage kidney disease on hemodialysis and non-hemodialysis, comparing those two different management groups. And I did this in Uganda. So just to give you context, Uganda is a country with only 12 nephrologists. The number has grown exponentially in the last 5 years, which we are very proud of. We have a population of about 45 million and growing. We have less than 100 hemodialysis machines. I think this is almost like most sub-Saharan African countries. Minimum costs of care are really high, so about $5,000 for a transplant, and even more. So 5,000 is for your basic immunosuppression medication, and the 25,000 is for the surgery itself. So just to put this into the context of the average Ugandan, 77% of our people dwell in the rural areas, just like Kato, who we are going to discuss. And they usually earn $20 or less. So hemodialysis is not something which is accessible or feasible for most of the Ugandans. And this is the map of Uganda. Those two red dots are the only places where you can get hemodialysis in the country. So everybody else staying in all the different parts of the country will have to travel to those two areas to be able to access hemodialysis. That's the context. So the study was a mixed methods longitudinal study. We recruited patients with end-stage kidney disease, both on hemodialysis and not on hemodialysis. We call those the non-hemodialysis group. We followed them up for 12 months, collecting data at 0, 3, 6, and the 12 months. And we hoped to measure and compare their health-related quality of life scores. We also hoped to measure the palliative care needs and the outcomes, and to explore how the treatment modalities affected the patients, and to see what their survival was, as well as explore their lived experiences. So we screened 1,500 patients, ended up with 410 patients who had end-stage kidney disease. The majority had stages 1 to 4, so are not eligible for entry into the study. And then when we broke it down, we had 240 non-hemodialysis patients and 120 hemodialysis patients. We had more non-hemodialysis patients because we suspected that they probably may not be able to live through the 1 year. We didn't know what we would find, but we thought it would be prudent to have more non-hemodialysis people in the group. So we used the kidney disease quality of life short form version 1.3 to collect our data. This tool looks at quality of life in 3 main dimensions. So the first dimension is the kidney disease specific concept. And then the other 2 look at the physical health and the mental health and how kidney disease impacts these concepts of a person's life. So the kidney disease specific domain looks at, first of all, what the symptom burden is, how the kidney disease is affecting the patient, the burden of the disease on the life of the patient, the burden of the disease on the cognitive function, and all those different aspects as listed here. And in the physical section, we look at how the physical health of the patient of the person is, how it is affected by the disease, but also how it affects the patient and the way in which they live their lives. And then the mental health looks at things like the emotional well-being of the patient, how they are functioning socially, and if they are tired and fatigue is affecting the way in which they look and perceive their lives. So what we found is that, first of all, the overall quality of life was very low. So if you look at the red, where the red points are highlighted, that tells us the overall quality of life in the different domains that we talked about. So the kidney disease domain, so 48 was the mean average score for patients who are on non-hemodialysis, and 53 was average score for patients who are on hemodialysis. A score of 50 and below is considered a poor quality of life. So overall quality of life is poor because the score is out of 100. So it's 53 out of 100 and 48 out of 100 in the kidney disease domain. And then in the physical health domain, things get a little bit worse. So it's almost the same for both the non-hemodialysis group and the hemodialysis group. If you look at the p-values, there's really no difference between these 2 scores. So it means that our patients who are on hemodialysis and not on hemodialysis have low quality of life, and there's really no difference in the quality of life of patients who get hemodialysis or those who do not get hemodialysis. So overall scores, as you can see, are 40 for the non-hemodialysis group and 41 for the hemodialysis group. So overall, they both have low quality of life scores. And then if you follow them up over the 3 months, over the 12 months period, I just look at the parts which are highlighted, the purple parts which are highlighted. So if you look at the 3 months period, every time we were in contact with a patient and screened them, we found that, for example, social support declined over the 1 year period. And this was not uncommon, because usually what happens is that when a patient is ill or unwell and they're admitted in hospital, everyone in the family, everyone in the village comes to support the patient, to see the patient, to see how they can help the patient. But with time, because this is a chronic illness, over the 1 year period, the people begin to go on to other things. Life takes over, they get other things that affect the way in which their life goes. And we find that, for example, for social support, which began on a high note at 75 as a score, over the 1 year period declined to 27. The same applies for dialysis staff encouragement. And then some of the things actually got better. So for example, emotional well-being increased a little bit, although it was significant. It was from 51 to 61 over the 1 year period. Role limitations due to the emotional well-being as well as social functioning improved. And we think that this could have been because these patients were maybe put on dialysis and they got better, because this is looking at the picture of both hemodialysis and non-hemodialysis patients. So overall, there was no difference in how the quality of life changed over the 1 year period. It was still not good, regardless of whether patients were on dialysis or not on hemodialysis. And then looking at the survival of these patients, there was really no difference in the overall survival of patients over a 1 year period. So the red graph is for the patients who are on conservative management. The blue graph is for patients who are on hemodialysis management. And still, there was no difference in the survival between the two patients. But also, the survival was actually really not good. So out of all the patients that we had, only 24%, which is a quarter of the patients, were able to survive up to the 1 year. And mean survival for most patients was actually about maybe 7 to 8 months for both groups. And there was really no difference in the groups. So we are giving them a treatment, but there's really no added benefit, it seems, in our setting for putting patients onto hemodialysis. And then looking at the patients who we get, this is not my study, this is a study from Masaka. Masaka is that purple dot, which is a small district in between Mbara, this is Mbara and Kampala. So just looking at the patients who come in, we found that many of the patients who come in have abnormal kidney function. And the abnormal kidney function that these patients come in with is not detected early enough. So these are all the patients who will eventually end up with end-stage kidney disease. And then also looking at the outcomes of these patients, most of the patients ended up dying without having access to hemodialysis, for example, or access to specialist kidney disease care. And this is not something that only happens in Uganda, but I would say probably something that happens in most of sub-Saharan Africa. So outcomes again in sub-Saharan Africa. Now this is looking at data from Nigeria. They had a study of 320 conservative hemodialysis patients. 80% of these patients had to pay for their dialysis themselves out of pocket. And the mean duration of patients who were on dialysis was again low, slightly lower than our study, but theirs was about maybe 3 to 4 months. And 40% of the mortality was at 90 days. So outcomes in this Nigerian study were as low as in our study. So then the qualitative aspects, looking at the lived experiences of patients, because we interviewed some of the patients who we had, and these are the key things that came out. So the first was looking at the spiritual health of the patients. So we found that faith and hope played a really big role in the way in which patients viewed their lives. And this is just one of the quotes for the patients. So the patient said, from the time that they were able to explore their faith, they found that they became strong. They were able to, the time when I drove my car, I reached and parked, I saw now I was going to leave. I also put on my shoes, went into church, praised God, and I could see that everybody was coming to touch me. So this, for him, being on, this is a patient who was on dialysis, this is, and got better from being on dialysis. They got derived so much hope from being able to interact with their people and showing them what they actually could do well. And this increased their spirituality and their feeling of being part of the community. And this is for this particular because they were put on dialysis. And then physical health, bodily changes affected the way in which they perceived themselves. So, for example, patients who are on dialysis, when they would see their feet swell, when they would see their skin darkening, and in particular, in our setting, we have a word called umurwadde, the patient. When you become sick and you become sick for a very long time, it becomes your name. People begin to call you umurwadde. And this is a patient who did not like being called umurwadde because she said that this is not my name, but everybody calls you that. And it changed the way in which she felt about herself and the way in which she interacted with other people. She started to hide away from the community because in some cases, the community did not even understand that this was an illness that would not go away in some cases. And then the social health, families were troubled by the separation that they faced. So for example, you saw in the picture where I showed you about where dialysis is available in Uganda, and many patients who stay up country, when they move to Kampala and they have to look for accommodation and stay in Kampala, it usually means that they are away from their livelihoods. If they work up country, they're away from their families. And this separation really makes them feel very low. And then looking at psychological health, it was costly, and many of them had to sell property to be able to keep up with the life that dialysis made them have to live with. And in selling the things, the consequences that come with selling your property is that your family members don't get what they would ideally get. And in this case, for this patient, it meant that the children were not able to go to school. In other cases, it would mean that maybe you're not able to have a home in which you live because you're selling your house, and other effects that follow that. And then looking at the daily lives of the patients, information was a key deficiency that the patient had, but then diet, because food is a big part of our society. Every time you have a gathering, every time you have a get together, it's always about eating food. So patients with end-stage kidney disease, when they have to pick and choose what they can or what they cannot eat, that becomes a problem for them. In our particular setting, people like to eat matoke a lot. So when you tell them you cannot eat matoke because you have end-stage kidney disease, that really affects the way the patient looks at food and looks at their lives. So diet was a big deal for patients. So our conclusion was that, first of all, a diagnosis of end-stage kidney disease really changed the life of the patients and their families. And the three ways in which it did is that the patient's social circumstances were greatly affected. The patient's personal beliefs are also equally affected, their perspectives on their life, but the duration of the illness determines the patient's experience. So patients who have been sick for a much longer time have a different way in which they perceive the illness. So time has a modifying factor in the beliefs of the patients and the quality of life of the patients. So as patients live longer with the disease, they gain information, they change their perspectives. And in many cases, we found that many of these patients could have some aspects of their quality of life improve and some aspects of their quality of life not improve, but time does affect the way in which quality of life changes. So it means that to improve the outcomes of patients who have end-stage kidney disease in our settings and in other resource-limited settings, then you have to be able to provide a patient-centered multidimensional approach, which should look at the financial, the cognitive behavioral, and incorporate educational interventions into the healthcare systems. So educational interventions augment the time the patient spends with the disease, but it also helps the family to make informed decisions. So just looking at the global picture, we know that the burden of end-stage kidney disease is really high, and there is a high need for renal replacement therapy. The study by Liange et al. In 2010 showed that 2 million people received renal replacement therapy in 2010, and they estimated from calculations that 4.9 people were needing renal replacement therapy. So that means that there's a deficit of people who should be getting renal replacement therapy but do not get it, just like it happens in our settings. Patients who are staying, for example, staying up country, who are staying far away, who start dialysis but eventually stop. So the number of people who are dying prematurely because they're not able to get these services are very many. And the gap will continue to increase with time and as the population grows, and the gap will be most felt in Asia and in Africa. This is our people. So if we have so many people who need renal replacement therapy and we have very limited resources, what do we do? What options do we have for them? So one of the options that we are offering is to incorporate palliative care into renal care. So palliative care is an approach that aims at improving quality of life, not only for patients, but also for their family. And the ways in which it wants to improve quality of life is by preventing, or if it has already happened, relieving suffering by looking holistically at the patient. Palliative care was founded by Dame Cicely Saunders, who passed on, but she came up with a concept that looking at the patient and telling the patient that you matter till the very end of your life is the essence of palliative care. And how you do this is by interacting with the patient and the patient's family. She came up with a concept of holistic care or total pain, which looks at 4 dimensions of pain or of suffering or of the patient's health or of any chronic illness that the patient may have. So you look at the physical aspect, which is what we usually concentrate on as care providers, and then look beyond that to the social aspects, like we talked about earlier. Our patients who have renal failure and they come into the hospital, they don't come alone. They come with their attendants. So who is supporting them? And the ones who come alone, you will see, for example, on our wards, we will have, say, for example, 2 nurses looking after 50 patients. Without a caretaker for that patient, they will struggle and they will suffer and mortality will be high. And then looking at the psychological aspect of the patient, how are they feeling in their minds? And looking at the spiritual aspect of pain, it helps you to be able to provide a more holistic care if you look at all these 4 dimensions of pain. So this is a quote from one of our patients. This was a refugee gentleman who had been on the ward for 6 months, sitting on the ward because he couldn't go home. He was scared of going home, and he couldn't leave the hospital because he was scared of going home. He had a lot of edema and he had lost most of his social contacts. He had lost his child, he's lost his wife. And this is what he said. But the most important thing for me is he said, I'm like on a pause. I feel like my life is on a pause. So he really doesn't know if he's going forward, if he's going backwards. He's just there trying to figure himself out. So this gentleman had more psychological and social issues than the physical issues. So renal supportive care has exactly the same definition as palliative care. The only difference is that you're focusing on patients with kidney disease and doing exactly the same things that you do when you do palliative care. So in other words, all of us are essentially doing palliative care. It's just that we have not admitted that we're doing palliative care. So which patients are eligible for palliative care? So for renal supportive care. So these are patients who have a high symptom burden, which is essentially most of our patients, who have high physical, psychological burdens, but also social and financial burdens, patients who are being managed conservatively because maybe they cannot access renal replacement therapy or they cannot afford renal replacement therapy. And then the priorities in providing care is, first of all, trying to be as patient-centered as you can. So talking to the patients and trying to sort through their problems, because the social problems for one patient are definitely different from the social or psychological problems of another patient. And trying to focus on their quality of life, trying to manage the symptoms, and also looking into the psychological and social support for the patient. And the strategies is to be as flexible and as practical as possible, because the scenario will change from patient to patient. But most importantly, because you are in the situation and you're in the setting and you know the patient, you're the best placed person to be able to provide the holistic care for the patient. So quality of life is really the perception of the patient in relation to their position in life, where they are, where they feel like they're in life. And successful kidney disease patients should always aim to improve the patient's quality of life. And this is what palliative care or renal supportive care aims to do. Quality of life is mainly, if there is an easy way of understanding quality of life is understanding the deficit for the patient between their hopes and aspirations and their reality. So for example, the refugee patient we talked about, the reality is that they're in the hospital, they are stuck, but they are hoping to be able to go to the hospital. And if you are providing care and trying to improve the quality of life for this patient, your aim is to bring as close as possible the reality of the patient's life to their hopes and aspirations. If you can bring these two together, then you have improved the quality of life of the patient. So the key aspects of renal supportive care is, one, you have to be proactive in symptom management and symptom assessment. You have to be able to estimate and communicate prognosis to the patient. You have to be able to include the family into the care and make a shared decision. So the family of the patient, because it's chronic illness, the family of a patient is a big part of the care that you give to the patient. You have to be able to make advanced care plans. So that's, for example, a patient who is at CKD at EGFR of 15, and you know that they're eventually going to progress to EGFR of 5 and need dialysis in the next maybe 6 to 12 months. So talk to them early, understand if dialysis is an option for them in our setting, and explain to them what it means to be on dialysis. And this is the providence that we're talking about when we're talking about Hippocrates. So if a patient is able to afford dialysis, then plan, get the fistula done, get them onto a pathway to get into dialysis. If that is not an option, it's not possible, then plan for how you're going to get the supportive care on board and who is going to provide the supportive care. And then with palliative care, it doesn't stop at the death of the patient, but it goes beyond to bereavement care. So this is the model of what we talk about when we talk about palliative care or renal supportive care. When the diagnosis of end-stage kidney disease is made, or even kidney disease, then what we do is we give renal supportive care. I mean, we give our usual disease-modifying care. So if they are diabetic, they continue with their diabetes management. If they are hypertensive, continue with their hypertensive management. If they have pulmonary nephritis, continue with your immunosuppression medication. So the PAPO is your disease-modifying therapy. It continues just as the disease progresses, even your disease-modifying therapy progresses. And then the orange is the palliative care. So initially, you will not have a lot to do regarding palliative care for this patient. Probably the initial things will be communicating with the patient, teaching them about their disease and their prognosis. But as the patient progresses towards end of life, the disease-modifying therapy eventually reaches its end point, but the palliative care continues until death and beyond, because you're going to do bereavement care for the family so that the experience of losing their loved ones is modified and the patient and the loved ones are able to continue with a good memory of how their patient passed on. So it's what they call in palliative care a good death for a patient. So the patient died, but the loved ones were able to be supported beyond the death of the patient. That is the model of what palliative care and renal supportive care would ideally look like. Now, prognosticating is just as important because it helps you to see how much palliative care, how much care you're going to give to the patient. These are the different models when you prognosticate for different diseases. So this is cancer, this is organ failure, including renal failure, and this is patients who have dementia. Just focusing on the patients who have organ failure, renal failure, the progress towards death is much, much slower compared to other illnesses. But you have these episodes when the patient gets very badly off and then gets better, and then another episode of a dip and then gets better. So understanding this and communicating this with the patient helps them to understand the prognostication better and therefore planning for the end-of-life care. So how do we integrate palliative care into normal routine care for patients and their families? So this was a study in University of Virginia, and they looked at social workers, registered nurses, and physicians, and they asked them about how they were able to integrate palliative care and what they thought about palliative care. And what they showed is that the MDs and the nurse practitioners felt comfortable initiating the conversations, because it begins with the conversations with the patient. The nurses were less comfortable, probably because they didn't do it as often as they can. And most of the clinicians would begin palliative care at the end of life, which is not what it should be. It should be begun when you make the diagnosis. And they thought that the primary barrier was because they're not able to communicate between the nephrology team and the palliative care team. So if you do have a palliative care team in your hospital, it's good to begin to talk with them earlier so that you get them involved in the patient's care. And as the patient's care extends towards the end of life, then you devolve into a more specialized palliative care rather than a renal care. And as you gain the experience, probably the nephrologist will be able to take over the care until the end of life. So is there really any difference in symptoms at the end of life versus in looking at patients with end-stage kidney disease versus those who have other diseases? And the answer really is no. The functional status is almost the same. Patients who have cancer, for example, or other severe diseases compared to renal diseases are almost the same. There's not much of a difference. Anxiety is almost the same, really. Looking at patients who have kidney disease and non-kidney disease, they all get anxiety, they all get nausea. Pain was a little bit different. Patients who had kidney disease had a lot more pain compared to those who did not have. And dyspnea may have been a little bit more for patients who have kidney disease. And then goals of care and advanced care planning were some of the reasons why patients were often referred. But what they found is that when you instituted palliative care, patients who had renal disease improved much better in their anxiety compared to all other patients. So palliative care actually is helpful for patients who have renal disease, and renal disease patients have almost similar symptoms compared to other severe illnesses. So this is really like an example of a model, a pathway to care of integrating renal supportive care into our routine care. So you would ideally begin by having a conversation which helps you to make the decision for the patients. And again, this is not a one-time conversation. It's a conversation that you'll have over and over and over again. And what you're aiming is not to prolong life, but to make the patient as comfortable as possible and to help the patients and the families to work together to have a good end of life. So then you would go to a stabilization phase after the decision phase, and then you would go to the death, end of life phase, and then the bereavement phase. This is how you would be progressing through. And it is a multidisciplinary kind of care that you would have. In our setting, we may not be having a dietitian, we may not be having a physiotherapist or social worker on board in most of our settings. And probably that is why we do not have a big difference in quality of life between our patients who are on dialysis and not hemodialysis. Maybe because we're not instituting the holistic aspects of care. But this is what ideally the interdisciplinary team would be consisting of. Then information is really important. This is looking at a study from cervical cancer patients in Uganda. And we know that patients had a need for information. There's always a fear that we don't want to tell patients that their life has been short or that they're going to die in the next 6 months or in the next short period of time. That is, I think, the way in which we think of care at the end of life. You don't tell the patient that you're dying because we feel like this is not something that you can easily tell the patient. But the reality is the patients actually want to know, because when they know, they're able to make plans, they're able to say, okay, then I want to do this, I want to do this with my time, I want to talk to this person. And that kind of, time to be able to plan and to prepare and to get their affairs in order. So if you give the patient this information, you help them to be able to make these decisions and to make these plans. So this is the same thing, really. Patients want to know. They want to have this information. So looking to Kato's case, our 18-year-old male. So what is it that Kato and his family want? And how will you approach this scenario? I will ask the audience to give us what their opinions and thoughts are regarding this case. But I thought that the key aspects really are that Kato will want expert care. He will want very effective communication and shared decision making. He will want respectful and compassionate care. He will want a good environment in which to be cared for. He will want his family to be involved. He'll want his financial affairs and maintenance, to have his financial affairs discussed, as well as his maintenance. And his family wants to be able to maintain a safe environment for their patients. They want to be able to prepare for the end of life of a patient. They want to be able to extend care beyond the family, to know what the patient's wishes were, so that they be able to know, for example, where he would like to be buried, what he would like to leave in his will. And these are the kind of conversations that need to be had rather than feared or avoided. So basically, principles of palliative care are the same principles as renal supportive care. And they look at applying principles of justice, autonomy, maleficence, non-beneficence, weighing benefits and burdens, whether you think that dialysis will benefit your patient or not, finding a balance between these two. We don't aim to prolong life, but we also don't aim to shorten life. We want the patient to have a good life for as long as they can. And we want to support the family as well as the patient during these final times. Thank you. And I hope that we shall have a fruitful discussion and lots of questions after this.
All right, Peace. Dr. Peace, that was excellent presentation. And I will pass it over to Dr. Marin. Dr. Marin is a physician and medical director working with AHN in Kenya, Nairobi. So, but before I pass it over to her, I have one question, Dr. Peace. I was actually surprised with the results. If you look at your Kaplan and Maya survival cup, where there was no any difference between those who were on hemodialysis and those who were on conservative treatment in terms of survival after being followed up for 1 year. I don't know, I would maybe the thing that I wanted also to know about the patients, the type of patients that were on hemodialysis. Were they doing it 3 times a week? The KT overview, how was it? You know, so it is a bit surprising. And another thing, that is number one. Number two is the palliative care. Maybe in the future we should do the costing itself, because you clearly presented that those patients who fit for the palliative care are those who are on conservative treatment. That the one that fits well in palliative care. But if you look at the palliative care itself, you need pharmacists, you need a nurse, you need psychologists, probably you may need orthopedic surgeon, dermatologist. So if you cost the services of all those people, you might find out that maybe the cost of hemodialysis is equal to the cost of palliative care in those particular patients. So back to you, Marian, and Dr. Peace, please, you can proceed with my question, the answer of my questions.
Okay, thank you so much, Dr. Ngina. So that's a very good question, and I was hoping that somebody would ask it. So why was there really no difference in quality of life between the two groups? Okay, so the reason why is because we think that maybe we're not doing a very good job with the dialysis we're providing for our patients. Most of our patients, first of all, they pay for dialysis. So because they pay for dialysis, they end up doing it very irregularly. So some of them will do it once a week, some of them will do it 2 times a week. And because of this, you find that you're not doing a very good, you may have a good KT/V for that one session, but because you're not doing it regularly, then maybe that diminishes the benefits of dialysis. You saw in one of our quality of life, there seemed to be some improvement in maybe the physical, that dialysis maybe improved a bit the physical aspects of quality of life, but overall survival was not that much better for the dialysis versus the non-dialysis group. So this is actually making us think about the dialysis that we offer, because the way in which our government provides dialysis is that if you do it 2 times a week, you do it at a subsidized cost. So maybe we should increase the subsidized dialysis to 3 times a week, so that people can have good dialysis if they are to have dialysis. But this maybe would mean that fewer people will be able to have dialysis. So of course, then the question comes up, is it better to give few people a good quality dialysis, or should we continue to give everyone dialysis, fully knowing that we're not really doing a good job with the dialysis? So a lot of questions come up with this, but what we know for sure is that we need to do better with the dialysis that we offer to our patients, because it doesn't seem to be better than the conservative management that we're offering. And then looking at costing palliative care, that's a good question. And that's what everyone in palliative care is trying to do now, to cost palliative care and see if maybe it is actually cheaper than dialysis. Some studies in other settings have shown that palliative care actually may offer a cheaper option of care, because you will have less utilization of hospitals, for example, less hospitalizations, for example, patients who are dying at home, less interventions, for example, CPR or ICU, once you decide to, for example, DNR a patient. So the cost of palliative care might be lower in some settings, but we're not really sure about in end-stage kidney disease. And that's, I think, a study that needs to be had. Thank you, Dr. Ngina.
Thank you.
Thank you, Dr. Ngina, and thank you, Dr. Peace. So that was a really interesting discussion of 2 similar studies that we've had that were conducted at the Kenyatta Hospital. Initially in 2014, we had a study that was looking at, the determinants of health-related quality of life of patients on maintenance dialysis, and they found indeed that the health-related quality of life was reduced, more so for physical quality of life versus mental quality of life. And then just last year, we had another study still published from Kenyatta Hospital with regards to the burden of depression amongst the patients we're dialyzing there. And we found actually there were almost 32% of our patients suffered some form of depression, 24% mild and thereabouts. So, I mean, this is something that really affects our region deeply. My question is simply that now that we've established that we have this palliative care available, who should we train to be able to initiate this type of palliative care and kidney supportive care at diagnosis and at follow through, because we only currently have, for example, 1 palliative care physician in the whole country. So how would we go about this? What would be your recommendation? Thank you.
Thank you so much, Adam. That's a good question, and that's a prevailing question. I think nephrologists need to have some training in palliative care. It might be minimal training to begin with, but like I said, as you see more patients, practice more palliative care, you become more adept and you're able to handle patients even at the end of life. So I think, and I know that there's actually now nephrology fellowships in palliative care. So I think nephrologists, because you are dealing with these patients on a daily basis, have to have some experience in palliative care and have to be able to provide renal supportive care. So not just nephrologists, but also nurses, nephrology nurses. So that because you're the ones who are going to identify the patients, identify what their needs are, and then probably communicate with the palliative care teams. Again, with the resource limitations, it becomes difficult, and the time constraints, because it takes time to sit down and have a conversation with the patient. So it's a huge problem. But I think that if we train nephrologists, at least get their mindsets tuned to this, it would be a good beginning.
Thank you, Dr. Peace. Then I'll just move on. We have a couple of questions in the chat box. We have one from an anonymous attendee who says, out of curiosity, are there plans or processes in place to improve accessibility to renal care in Uganda? National insurance to cover dialysis, any hopes? That's our first question.
Maybe to answer that, the answer is yes. There are plans to offer subsidized dialysis regionally. We also have had ongoing plans for our national health insurance system, and that is still ongoing. But as far as dialysis is concerned, we have ongoing plans to extend dialysis to regional referral hospitals beyond just Kampala.
Thank you very much, Dr. Peace. And if we have any more questions from the audience, we could just type them in the box or.
Is Dr. Furia, sorry, Mary, Dr. Francis has raised her hand.
Yes, thank you guys. I think this has been a very interesting talk, and thank you, Doc, for presenting this. And I've really enjoyed listening to your talk. And I guess my comments will be the fact that I understand when we are talking about palliative care and conservative kidney care, we are using the guideline and protocols that were developed for high-income countries. You know, you're looking at the countries like US, Canada, Australia. These are the people that are saying that palliative care should be going for patients that have multiple comorbid conditions who might not benefit from dialysis or kidney transplantation. The picture might be completely different when you come to our setting, because you have young people who might not be able to access dialysis. And even if they access it, they might not be able to sustain, the cost. And I like the fact that when you're looking at the palliative care, you are bringing in the multidisciplinary approach, because when you're looking at the patient from the point of view of other specialty, the social aspect and social circumstances of this particular patient, you will come to realize that even if you give them free dialysis, they might not be able to uptake these services. We have tried to give free dialysis to patients and 3 times a week, but then oftentimes they will not be able to come in because they don't have transport. They don't have food. They can't have food at home. They cannot pay for transport to come for dialysis, which is given for free. So the cost that you pay if you're giving it for free and these patients are not able to afford even transport, they will not be able to afford other medications that they need. They will not be able to pay for EPO. They will not be able to use ferrous sulfate, and they will be invariably anemic after every 2 weeks. So you have this patient getting admitted every other week with severe anemia, needing blood transfusion several times. And as it is, the patient will definitely lose their life in 3 months in a miserable way, because they will have sold everything and they will leave behind a very destitute family and a lot of bills that need to be paid. because they have to incur a lot of debts to sustain their life in that cause. So I definitely understand that this is care which is really important. And when we're looking at it, we need to look at it as an alternative. And of course, it needs to be extended beyond patients with multiple comorbidity and those that might not benefit from dialysis from the medical point of view. Because if you have a patient that is going into debt to sustain their coming to dialysis, they will also not benefit from it because it's equally as bad. So when we're looking at these multiple comorbid conditions, we should also look at the social aspect of these circumstances of the patient. But otherwise, I really enjoyed your talk, and I think this is something that we need to think when we are really going into scaling up and increasing the access to dialysis. Which patients do we put in dialysis, and what is the outcome, and what do we want to get out of it? Thank you very much, and these are my few comments. I really enjoyed your talk. Thank you.
Thank you. Thank you very much. I agree. The demographics are different, and that's why the case we're talking about is actually an 18-year-old boy who comes in with all of his social issues coming from a rural part of the country. So the demographics are entirely different, and therefore the guidelines that are used in developed countries are going to be different from the ones that are used in developing countries. Thank you so much.
Okay, we also have a question from Dr. Robert. Dr. Robert, would you like to speak?
Thank you very much, Peace, and the team for a very wonderful talk. My question is just carrying on from Dr. Freer's comments. I know we are trying to expand dialysis and in Uganda, for example, but your study is telling us otherwise. So in your opinion, I know Dr. Chigun Daniel is also on this. In your opinion, if there is no difference in survival between those who have dialysis and those who don't have, and this is not because usually the people who don't have dialysis are different demographic, it's because they just can't afford that least amount of money to be paid. Would it be wise to now expand this dialysis that is not offering any financial benefit, or would you rather first improve and make a significant difference? What are the key what you would think forward? I heard you, South Africa has some model that kind of looks, but I would perhaps if Daniel could also speak to this, that would be very welcome. Thank you very much. Otherwise, it's a very wonderful talk, and we do appreciate you for doing this work, which is bringing these difficult things into the scientific world. Thank you.
Thank you. I think that's a very hard question to answer, but I think that one, if you look at it objectively, like step by step, the first thing we know is that we're not offering a very good dialysis session. That's number one. The second thing we know is that because we're not offering a very good dialysis session, we're not really improving quality of life for our patients. So baseline, we have that the quality of life is poor. So the next step really would be to see what interventions we would like to give to be able to improve the quality of life. And also, one of the things that we know is that we have a tool that we can use to measure quality of life. So whatever intervention that we put after this, we can always measure and see if it is improving quality of life or not. The next thing is that should we expand a service which is not working? My inclination is that it should be expanded. And the reason why I think it should be expanded is that because then you're able to reach more people, but we need to improve the basic things that can be improved, like giving information to patients, telling them early enough that this is what you might be able to get from your palliative care, and also educating the patients. Education as an intervention, for example, is not a very costly intervention, but it's likely to improve outcomes of patients. And also trying to have a 3 times a week subsidized session might actually, if we do have more facilities, may be a better idea than only having a 2 times a week service. That is my take on that. I don't know if Dr. Chigundu would like to add what his thoughts would be on that.
We had 2 additional questions too, if you'd allow us. We have Dr. Elliot Tanner awaiting. Could we allow him to ask his question too?
Yes, please.
Yeah, thank you very much. So Peace, I think I couldn't start off the presentation, but at least the few I had, I really enjoyed it. And I think this study, I mean, which you are currently projecting, it's such an important study. I've not had the courage to do a study like that, but I probably would not be surprised at what you found, so far as survival is concerned. But my question on this one would rather be, I mean, I have a key interest rather in quality of life, I mean, than just survival. That I don't know whether you guys were able to study quality of life somewhere along the line, say 6 months or 3 months or 9 months, whatever, in the course of this particular study. I think that would be my question. But I think some comments I would want to throw in, which I believe is something that we should be looking at, is the fact that our kind of people, yes, are relatively younger. So it's not a question of whether or not to consider palliative or not. It's more conservative just because they cannot afford. Because you cannot look at somebody who is 43 or 24 and say, okay, you probably cannot, go on to dialysis, but rather the question is as to whether they can afford. I mean, in places like Tanzania and all, where some bit of offering, so far as dialysis is concerned, helps out. In Ghana, Nigeria, you have to cough everything out. And I think one of the major difficulties why I would think that quality of life, even among the patients on dialysis, might even be worse than even the ones on conservative, is the fact that they crash land, they would have to be, a catheter will be inserted, they might get infected, they are hospitalized, their blood levels are low and stuff like that, So there are a lot of things that tend to mitigate against, so to speak, normal, good quality dialysis. And for that matter, might end up with us seeing what we are seeing on the screen as it stands now. So my interest will be more of what is the quality of life differences amongst these two groups of people? And in any case, how best can we improve the quality of life? And at Peace, I like what you said in the sense that every nephrologist, I don't know how you can practice nephrology in Africa and not be good at managing conservatively, because I think that is what we do more of than even the patients on dialysis, and I stand to be corrected. Thanks, Peace. Wonderful presentation.
Thank you so much, Elliot. I completely agree. I think 80% of the work we do as nephrologists is really supportive care. You're very right.
Absolutely.
And then sorry, on the quality of life bit, did you guys look at quality of life?
Yes, Elliot. We looked at quality of life, and there was, this is one of the things that we projected, was not much difference in quality of life between the two groups. And at the different time points, it's only different aspects of quality of life that improved, but overall the quality of life was very low for both the hemodialysis and conservative management group. So yes, we are not doing a very good job of improving quality of life for our dialysis patients overall. And again, our patient demographics are entirely different. Our patients are not elderly and multi-morbid like you'd find in most guidelines or most developing countries. So younger patients not having a good quality of life is really a sign of not just the physical, but the psychological, the spiritual, and the social aspects of life, which I think we need to look into and need to find ways of alleviating, and not just concentrating on the physical health of patients.
Absolutely. And then we move on to the next question from Kenyanya Monda, that is there a criteria for selecting the category of patients who are placed under palliative care, considering the benefit of transplant? And then we also have Dr. Manjusha, who's raised her hand, so we can have both questions go on at once.
We would like to hear from Dr. Manjusha, and then I'll answer both questions.
Yeah, thanks. Thanks so much. I think it's lovely to hear to the discussion out here. I have a different perspective. I'm from India. So one is regarding the palliative care. Of course, it needs to be included in the trainee curriculum to understand what exactly is a palliative care, what are the indications that a patient goes into. What I understand after listening to the talk as well as little comments from Elliot is that we have two different types of society wherein it's a paying society and a non-paying society, in the sense where we deliver the dialysis services. So if it's a paying patient, obviously the conservative preference probably is more, and compared to when we have a non-paying scheme, like the country where I am in right now, the state where I am in right now, we serve about a good number of patients of dialysis and a non-payment cashless government funded scheme, like an insurance scheme where the patients do not pay anything for the dialyzer or the tubings or the services or the erythropoietin or even for the travel that is being given. Apart from that, there has been a recent introduction for the pension in the form of an amount of about 2,000 Indian rupees per month to each and every patient. So this probably has enhanced the inclusion or the preference of the patients towards dialysis compared to what it was about 13 years back. So 13 years back, this cashless scheme wasn't there. So we could not dialyze many of the patients. It was more or less like a paying society. So number of patients was less. The travel expenditure was more. The out-of-pocket expenditure was more. And then over a period of time, we ourselves have evolved from 7 functioning centers to 42 functioning centers to at present 1 or 2 functioning centers in our own state of Telangana. So with this, we had seen people who are preferring the dialysis rather than the conservative, because non-payment should not force them to go in for conservative. I think we should understand that aspect. If a free dialysis is given, even then the patient is preferring a conservative after explaining the risk, probably that is a true conservative. This is what I understand, or probably a palliative. So when we looked at the out-of-pocket expenditure that was discussed just now, I mean, that has also come down by the patients, because earlier they used to travel about 300 kilometers to reach an accessible dialysis center. Now it's just 20 to 30 kilometers. Patient is able to go home. I mean, little expenditure on the medicines that he's supposed to take. Otherwise, everything is being delivered free of cost. So with this availability of the services and of course an improvement in quality of life, yes, I agree that we still have a high incidence and prevalence of sudden cardiac deaths in our groups. Apart from that, the quality of life that we had assessed using SF36, Frail's criteria, as well as Beck's inventory score. So all these things we have done in our groups of about 800 plus population under my center alone. So we had seen a definite improvement compared to what it was in the past. But there's a lot to be done, as has been discussed. So what I would like to emphasize is the palliative should be considered in a situation where if all the services are even available at free of cost, even then there are medical indications for the palliative care. Probably that may be the true entity wherein we should step in and of course expand the services of palliative care as well. After explaining step by step, it's not easy for a patient to choose a palliative care when we explain the pros and cons of dialysis. So if that is all, and that all needs health literacy. So there's a long way for us to go, especially in LMICs as far as the palliative care is concerned. But this universal health scheme, which is available in our country, LMIC, has been a successful model. So I mean, it's this thing to know that in Uganda scheme is available in parts, and then in Ghana it's not available. But definitely we can share our experience in a bigger way that these are successful models which can be implemented, which enhances the equity of the care and accessibility of the healthcare. So this is a comment from my side. Thank you. Thank you for the opportunity.
Thank you. Thank you. You've really summarized the difference between the two groups, and it's good to hear the experience that is happening in India. Again, there'll always be a difference between where patients are paying and where patients are not paying, and also the services that you offer when patients are paying and when they're not paying. I think in most of our settings, because of the out-of-pocket costs, it becomes a forced decision for conservative management. But still, as nephrologists working in resource-limited settings, we have to be able to provide both services to the patients and to know where to start and what skills to offer to our patients. Yes, thank you.
Absolutely. Thank you. Thank you so much. Yeah.
If I may, this is Daniel Chigundo. Thank you, Peace, for leading an excellent discussion on the realities of kidney care in advanced kidney disease in Uganda, in Africa. Thank you, colleagues, for sharing your experiences from around Africa and from India and valuable insights. I'd like to deal with a question that Peace and Robert grappled with briefly, which is whether we should make dialysis more accessible to people if we have uncertainties about what quality we are delivering. And I think that there are two groups that we serve with dialysis, which is the AKIs and the chronic kidney failures as well. And I also think that for the chronic kidney disease, what we'll be sending out is not simply dialysis machines, but a comprehensive kidney service whereby people are still able to have a conversation about what benefit will actually deliver to the patient, so that somebody who's 400 kilometers from the capital can have this conversation there and not have it after traveling 400 kilometers to be told that they can't benefit and they should or get stuck there. But I think we will not get to the right answer straight away, but it will be an evolution. But thank you very much, Peace and colleagues.
Yeah, if I'm allowed, can I make a comment at this point following this doctor's comment? See, what we have been doing after COVID pandemic is, yes, we have centers which are located about 300 kilometers away, but we do conduct regular Zoom or Google Meets to every patient possible, meet their requirements with respect to their complaints as well as the change in prescription as well with the help of the local doctor. So this is how we have been approaching. So what I mean to say is the distance should not matter in the background of well-developed technological developments in the society, which in fact an LMIC like us is also using extensively well. In fact, this week only we had a review of about 30 centers at a go in our state. So, I mean, it's not a difficult one in the background of a technological, devices or feasibilities which are available. So that can be done, and our principle is reach out to the patient rather than vice versa, patient reaching us. So that's the motto with which we are going ahead. Thank you so much.
Thank you all for those comments. I think in view of time, we have one more question we have from Dr. Grace. She's raised her hand. Dr. Grace, would you like to ask your question?
Thank you very much, Peace. Thank you, everyone, and thank you, Peace, for the excellent presentation. I am from Uganda, and I actually happen to be at a site where dialysis is expanding at the moment. And I totally agree with you, Peace and Dan, that it is okay to continue and expand dialysis, because yes, we know, like Dr. Chigunda said, that they are, especially the AKIs, that really benefit. So I can say that really from the past 3 months that we are expanded, we've had very many initiate dialysis. We've had very many AKIs go home AKI free because of dialysis. But also we have had, we have also had very many people stop dialysis. Start, yes, we're happy that they've started because they have this subsidized dialysis, but they have also stopped and withdrawn because of the cost. So as we expand, yes, Peace, like you say, as a country, we really need to rethink even the subsidized cost. How many people can afford it? Do we offer it 3 times instead of 2 to improve the quality of life? But then as many people access it, can they really sustain it? That's a question. And that maybe goes back to beg, when we are really counseling patients for dialysis and encouraging them to do this dialysis, and they are seeing that the initial cost is manageable, but how about the sustainability? So that really remains for us to think through. But I guess we all agree that yes, the expansion is the way to go. And when we look at palliative care and who should provide it, I think we still have room to think more about that. Much as every nephrologist, yes, needs to have palliative care, definitely that's a given. And every nephrologist, I believe, tries to to have that. But we still have to think and remember that very many patients still do not reach us. And even when they come and we say, okay, yes, they can't afford dialysis, they go, it will be very difficult for them to come for the conservative care back to the nephrologist. And I guess even if for most of us, or as we know, for example, in Uganda, that very many regions, they still do not have a nephrologist accessible to the patients. So then if I come from such a region, I cannot travel for dialysis. I have chosen conservative care. Who is going to offer this care? That the transport to bring me to a nephrologist is still hard enough for me. So we still need to think, as we want to offer this conservative care, who is going to offer it? Who other than the nephrologist can be trained to offer it? So I think those are still very valid questions for us in resource poor settings that we need to think about. But otherwise, great presentation, Peace, and great discussion, colleagues.
Wow, thank you so much, Grace. I think those are really good insights and good thoughts. And thank you so much, Daniel, as well. The thinking beyond the end-stage kidney disease patients to the AKI patients and how they benefit is something which is really worthwhile. And training people beyond nephrologists to offer palliative care is obviously one of the ways in which we can improve care, but probably also integrating it into all our nephrology curriculums for both undergraduate and postgraduate is something that we have to think about as we go along improving our trainings for future care providers. Thank you, Grace.
Thank you very much, Dr. Peace. And I think we've really had an amazing discussion, and on behalf of the AHN, I would like to thank you for your valuable time and your input and insights. We really look forward to having more such conversations with you, and we thank you once again from the entire team.
Thank you so much. Thank you so much, AHN team.
Thank you very much, Dr. Peace. That was a wonderful session indeed, and a true eye-opener. And I think the two things that we have not looked through in Rwanda, Tanzania, and Kenya, one has been mental health, and the second has been the quality of life. So these are two things that we really would love to look at. And the question about who would actually deliver, yes, I think it should be part of the nephrology curriculum, but I think we also have a larger pool of people who look after kidney disease, and that is the nursing pool. And quite often, we don't have time because the load is so much. The nephrologists are few. And I think they are the people who are more involved with, especially in our units. A lot of them are so very involved with patients. They know everything about the patient's lives. Some of them cannot afford transport. Some of them don't have food. Some of them don't have caregivers to come. Sometimes, the weather is not there. Sometimes, somebody is not well at home, or somebody, something happened at home, which is, so there are a whole host of things, reasons, again, non-compliance occurs. And so the quality of dialysis actually doesn't equalize conservative care. And so that's how the outcomes go. And I think even your study actually has shown that, patient's job makes a difference. That's something I saw in your study. And that's the same thing what Dr. Manjusha has said in India, where the government provides funds. So basically it is all economics. So I was just thinking loud to say, maybe we should have a dialysis nurse who should also be trained in kidney supportive care and probably a little bit of mental health. So, cognitive behavioral therapy. So mental health is also looked into, at least to an extent. I mean, we know that drug therapy may or may not, there's no real difference in mental health. But again, both this together, at least one or two nurses in the unit actually may make a lot of difference. So, I mean, I think that is something that I just wanted to add. And this is such a lovely session. And I'm sure we would be catching on you to help us see if we can implement QOL scores in our patients to know where we stand across in our centers in the 3 countries. Thank you very, very much for this wonderful session.
Thank you so much, Lloyd. And you're totally right. Nurses spend so much time with patients. I think training them and being able to provide these extra skills would be a good addition to nursing curriculum. Thank you so much for inviting me. I'm so privileged to have been here. The Fireside chats are a really inspirational. We thank you for providing them to all of us. We are very blessed to be receiving these. Thank you again.